Hi, my name is Christine Smart, licensed clinical mental health counselor. Today we're going to go over three of the most common eating disorders that we see in the country and in the world at large. So let's get started. Eating disorders. What are their names? What are their symptoms? What causes them? What are the risks? Can they be treated? In the US, it is estimated that more than 30 million people suffer with an eating disorder. That number jumps to 70 million worldwide. So what are the names of the three most common eating disorders in the country? Today we'll look at anorexia nervosa, bulimia nervosa, and binge eating disorder. To the right on the slide, you see the DSM-5 diagnostic code for each. So let's get started with anorexia nervosa. Some of the statistics are as follows. The average age of onset tends to correlate with the onset of puberty. Among those aged 5 to 12, it affects females over males at a ratio of 5 to 1. This ratio changes in adolescence and adulthood to a ratio of 10 to 1 female over male, with the disorder being most prevalent among those ages 14 to 60. It's estimated that between 0.5 and 3.7% of females will suffer symptoms of anorexia nervosa at some point over the course of their life. The occurrence may be slightly higher among the LGBTQ community, with a focus especially on transgendered individuals. There's a problem with statistics. The overarching issue is underreporting. This is especially common among males. And unfortunately, most of the sufferers of eating disorders tend to suffer in silence. Hence, the statistics may be actually much higher than what's reported here. So there are two subtypes of anorexia nervosa. The restrictive type, which consists of the individual depriving themselves of taking in needed nutrition and may consume as few as a few hundred calories each day. There's also the binge purge type, which consists of binge eating episodes, purging behavior, also called compensatory behavior. And purging behavior often consists of purging the body of calories by induced vomiting, the use of laxatives, or the excessive use of exercise. So what are some of the symptoms of anorexia nervosa? Something I think that's interesting to share before we get into the actual symptoms is that anorexia nervosa has the highest mortality rate of any mental illness. This according to the citation shown on the slide. For this reason, it is imperative to intervene as soon as possible when you suspect that someone is suffering from anorexia nervosa. This can be done by family members, friends, clergy, teachers, anyone that comes in contact with someone who they suspect is suffering from anorexia. Studies have shown that sufferers of anorexia are 56 times more likely to complete suicide than non-sufferers. This according to the citation on the slide. According to the Mayo Clinic, the following are the most common symptoms of anorexia nervosa, and we'll start with physical symptoms. I won't name them all, but I'll touch on some of the ones that are most significant. Low blood pressure, low body weight, dehydration. This can occur with dizziness, fainting, headache, low body temperature, and the other symptoms that are named here. Now the behavioral symptoms of anorexia nervosa. Some of them include binge eating, compulsive behavior, impulsivity, isolating oneself socially, irritability, depression, anxiety, feelings of guilt, feelings of being overweight or fat, even when weight loss, even significant, is obvious, a distorted body image, which is also known as body dysmorphia, and demanding personal standards. So what symptoms must be present to arrive at a diagnosis of anorexia nervosa? This slide lists the DSM-5 criteria for the diagnosis, which I won't read for you. Feel free to read on your own. However, I think it is important to note that it does summarize and touch on many of the points that we've discussed thus far. So what are the risks? Thus far, we've talked about the symptomology that makes anorexia nervosa a serious illness. Now we'll mention some of the specific risks. These include starvation, cardiac arrest, stroke, organ failure, and refeeding syndrome. These may all lead to permanent disability or death. Now let's take a look at something called refeeding syndrome. This is really important and a common occurrence as someone begins nutritional replenishment. This is when an individual has either chosen to or has experienced an intervention and has been forced to start eating again. Refeeding syndrome is caused by extreme shifts in electrolytes and fluids in the body as it shifts from starvation mode to what's called an anabolic state. During starvation mode, the body has literally begun to feed on itself to draw life-sustaining energy from within. When the shifts begin to occur, it increases the uptake of certain electrolytes such as potassium, phosphorate, and magnesium. This taxes the cardiac system as well as other bodily systems and can lead to cardiac, gastrointestinal, respiratory, and skeletal issues as well as permanent disability or death. So what are some of the risk factors for refeeding syndrome? These are some. A body mass of less than 18.5%, weight loss of greater than 10% in the last 3 to 6 months, little to no nutritional intake for 5 or more consecutive days, and a history of substance abuse. Given the threat of refeeding syndrome, it is recommended that during the early stages of nutritional replenishment that individuals be monitored closely by medical professionals. It's important to remember that relapse is a threat at any time during recovery. Now we'll move along to another eating disorder called bulimia nervosa. This slide has the DSM-5 criteria for a diagnosis of bulimia nervosa, which I'll leave you to read on your own, and we'll talk a little bit more about the disease on our next slide. So in addition to the DSM-5 statistics for the criteria to meet a diagnosis of bulimia nervosa, the American Psychiatric Association in 2013 states that another significant symptom is a profound negative self-view of one's body. It's estimated that 1.1 to 4.2% of females qualify for a diagnosis of bulimia nervosa in their lifetime. What's really sad about bulimia nervosa and not well known is that it's literally impossible to purge the body through compensatory behaviors of the caloric intake during a binge episode. So therefore, the person who suffers bulimia nervosa either doesn't lose weight or can even gain weight. So now we'll move into binge eating disorder. Here on this slide, again, are the DSM-5 criteria to meet the requirements for a diagnosis of binge eating disorder, which I'll leave you to read on your own, and we'll get into the symptoms more on the next slide. So binge eating disorder is labeled by the American Psychiatric Association as the most common eating disorder in the country. Lifetime prevalence in females is 3.5% of the population and 2% of the population among males. Again, the underreporting by both sexes is potential for these statistics to be lower than what they actually are. The typical caloric intake during a binge episode is between 3,415 calories, but can be actually much higher, as high as 5,000 to 6,000 calories. So this helps you begin to see, as we refer back to a binge eating episode in Bulimia Nervosa, how it's impossible for the body to purge itself of all of the calories during a binge episode, because by the time the binge episode is over, the body has already begun to break down and to digest the food that is being taken in. So now we'll move into treatment of eating disorders. Yes, there is hope. It's not all dark and murky. So the treatment approaches for eating disorders include any or all of the following. However, all treatment approaches promote regular eating habits and the use of positive coping strategies. So here are some of the theoretical approaches. Cognitive behavioral therapy, commonly known as CBT, dialectical behavioral therapy, commonly known as DBT, support groups, individual, family, and group psychotherapy, sometimes hospitalization. This most often occurs with refeeding syndrome, as we talked about earlier, and sometimes the use of psychopharmacology. These would be things like SSRIs, which are more commonly known as antidepressants. Some of the names of these are Zoloft, Prozac, Wellbutrin. Wellbutrin is one that works pretty well in the treatment of eating disorders because it really helps and is effective with obsessive and compulsive behavior. And at times the use of antipsychotics may be necessary for treatment as well. However, psychopharmacology is always used in conjunction with psychotherapy. So when seeking treatment for eating disorders, some of the specialists that you may want to seek out include therapists of varying backgrounds. I've listed some of their titles here: psychiatrists, primary care physicians, and nutritionists. So as we sum up, let's remember that there are several commonalities among eating disorders, and let's take a look at some of them here. The co-occurrence of other mental health disorders, like depressive disorders and anxiety disorders, as well as dysmorphic disorders. It's estimated that 33 to 50% of those diagnosed with an eating disorder also have a comorbid diagnosis. Trauma history, familial history of mental illness and/or eating disorders, similar age of onset and course, and treatment modalities for abstinence and healthy living. Remember, it's really important not to forget that eating disorders tend to represent something else that's going on within the individual. An eating disorder is a way that a person can exude control over their life. For example, if someone has a trauma history, no matter what age at which it occurred, what they put into and get out of their body is something that they may feel that they have control of. So as a therapist, always look deeper than what's on the surface. So many times when someone comes into treatment for an eating disorder, they're going to want to stick just to the eating disorder. But it's my belief and my approach that looking at the underlying criteria and constructs that feed the behavior of an eating disorder is what we really need to get at in order to maintain abstinence and a healthy lifestyle. Really think about what you're offering in therapy to individuals and do your best to not put them in one little compartment. Someone's life may depend on it. Thank you so much for watching. God bless.